This next video is going to focus on the practical aspects of non-invasive ventilation with a particular focus on the situation that we're in now and looking after COVID-19 positive patients, and it is based on the evidence that we have to date.
Hello everyone, my name is David. This session we're going to talk about the use of non-invasive ventilation in secondary care. What we'd like to cover is we're going to talk about the definition and very brief physiology of non-invasive ventilation therapy. We'll talk about some considerations on inclusion and exclusion criteria. We'll talk about setup and monitoring, and we will talk about recent evidence of the use of non-invasive ventilation in individuals in hospital with suspected or confirmed COVID-19. We will talk about interfaces, and we will show you how to apply an interface for a patient. And we'll finish it off by talking about some common complications or troubleshooting that you may need to employ when you're helping to manage a patient receiving this therapy. It's the use of a face mask that covers the structures of the mouth and nose, a tight-fitting mask that connects to an air pump. The air pump delivers positive pressure to improve ventilation for your patient. Why does your patient need support with ventilation? It's because they've been diagnosed with acute hypercapnic respiratory failure. So acute meaning sudden onset, hypercapnic meaning high blood carbon dioxide levels, and respiratory failure. Failure to maintain adequate gaseous exchange. And in this patient population, they're failing in the removal of carbon dioxide. By definition, we look at the arterial blood gases, and it shows a low blood pH, less than 7.35, and a high level of arterial carbon dioxide, otherwise known as a respiratory acidemia. The non-invasive ventilator provides assistance during the inspiratory phase of respiration, and it prevents airway collapse during the expiratory phase. This is done through the application of positive pressure. The positive pressure helps to improve blood oxygenation and reduce blood carbon dioxide. The positive pressure is delivered in two forms: an inspiratory pressure, known as IPAP, and an expiratory pressure, known as EPAP. Application of inspiratory positive airways pressure, or IPAP, it will increase the tidal volume of your patients. This improves alveolar ventilation, reducing carbon dioxide levels and reducing the work of breathing as well. As they breathe out against a lower pressure called EPAP or PEEP, and that helps to recruit more lung units and improve oxygenation. We will use non-invasive ventilation on ward level for individuals who have got an underlying condition such as chronic obstructive pulmonary disease or COPD, neuromuscular disease, morbid obesity or chest wall deformity. You'll see the chart that we've shown here, it comes from national guidance from the British Thoracic Society, and it helps to inform our local policy and protocol on the indications, contraindications and initiation of this therapy for the different patient populations. I would advise at this stage that you look at your local policy and protocol or discuss with your local respiratory specialist about what you do in your area for inclusion and exclusion criteria for these patients. I would like to bring particular attention to the indication criteria and the exclusion criteria, and you'll see what's promoted in this chart is that individuals who have got asthma or pneumonia are usually not considered for ward level acute non-invasive ventilation, and they should be discussed with our senior colleagues or perhaps the critical care physicians. Patients who require non-invasive ventilation do need a higher level of supervision, and we would encourage that for the first 24 hours that all of these individuals get continuous pulse oximetry and monitoring that their oxygen saturations are within their prescribed saturation range. We would encourage that they get intermittent monitoring of their pH and their arterial carbon dioxide levels through arterial blood gas monitoring, and we would also encourage they get continuous cardiac monitoring, particularly if their pulse rate is greater than 120 or if they're at risk of developing any arrhythmia or cardiomyopathy. Other components of your continuous monitoring of these individuals is to make sure that there's appropriate positioning, so positioning them upright in the bed, usually greater than a 45-degree angle, making sure the patient is as comfortable as possible while they're using this therapy, keeping a close eye on all of the components in your ABCDE assessment. In relation to the application of non-invasive ventilation to patients who are suspected or confirmed COVID-19, there have been some modifications. The modifications I make reference to is recent guidance that have came from the British Thoracic Society. At present, the use of non-invasive ventilation in individuals with confirmed or suspected COVID-19 must be discussed with senior medical or critical care staff. There may still be a role in using this therapy for patients with combined syndromes. And what I mean by that, they could be patients, for example, with an exacerbation of COPD, as described earlier in this video, who are suspected or confirmed COVID-19. But again, I must stress it should be discussed with senior medical staff. The modifications in giving non-invasive ventilation to these patients with suspected or confirmed COVID-19 is mainly in relation to the interface and the circuit. And we've given some pictures and we've given some information here on this session. What you can see here in this modified circuit is that if we start with the interface has been changed to a non-vented mask. And what that means is that the interface does not have any exhalation ports. As we work down, you're going to see from the mask, you've then got the oxygen entrainment port. Remember the purpose of trying to entrain oxygen as close to the patient's mask as possible. Next, you will encounter the bacterial viral filter. And the purpose of the filter is that when the patient breathes out, the expired gas does not go out to the atmosphere because the mask is non-vented. It goes back down through the circuit, through the viral filter, and it leaves the circuit through the carbon dioxide exhalation port, which is located below the filter. You can see on the slides it gives a more close-up view of what these components look like. The main reason for doing this is it helps to reduce the viral transmission of the COVID-19 virus to the atmosphere to protect healthcare staff in looking after these patients. I would strongly recommend, though, that when you're looking after patients with suspected or confirmed COVID-19, that you do consult your local infection control policy and guideline. Our practice at present for individuals who are suspected or confirmed COVID-19 is that independent of the NIV circuit or mask that you're using, we are still using full protective personal equipment as recommended by our local infection control policy. Next, I'd like to talk to you about the setup of this therapy. You'll see the components in front of me, which I'm now going to describe to you. First of all, you need to locate your non-invasive ventilator. And this is an example of a common non-invasive ventilator that we would use here. Once you have your non-invasive ventilator, you're going to need to locate the appropriate interface for your patient to use, and also you're going to need an NIV circuit in order to deliver the therapy. We start off by applying a bacterial filter here at the exhalation port of the ventilator, and it's assembled as so. Next, you're going to need to get your hose or your NIV circuit, and you'll see that one end is connected to the bacterial filter as so. As you come towards the top of the hose, you're going to see an oxygen entrainment port. The purpose of this fine bore oxygen tubing is to connect to oxygen therapy so you can deliver supplemental oxygen therapy if required. Our local policy is that we would like to entrain oxygen therapy as close to the patient's mask as possible. Next, we need to locate the interface that's required for your patients to receive this therapy. The interface we're going to demonstrate to you today is the most commonest interface that you're likely to come into contact with, and it's called an oronasal or full face mask. So it's a mask that's designed to cover the structures of the nose and the mouth. The components of this mask is that this is called a vented full face mask. And what I mean by that is that you can see here in the mask is that you get vents on the top of the mask to allow for, as the patient breathes out, their expired gas can escape the mask and into the atmosphere. You'll see here the elbow of the mask, and the elbow connects to your oxygen entrainment port like so. Once you have assembled your equipment, you will be ready now to apply this to your patient to receive their therapy. This style of non-invasive ventilator is switched on by pressing the button here as so. When you press this button, you will hear a beep and you'll be able to see some information on the display screen. On the display screen, I'm going to pay particular attention to the inspiratory pressure here and the expiratory pressure below it. For this system, we can adjust the inspiratory and expiratory pressure by using the buttons here on the side and adjusting it up and down with the plus and minus arrows. I would encourage that you adjust the settings as per your local policy. This ventilator will give me alarms and warnings to let us know if the patient is not receiving the desired therapy. This style of ventilator will give an alarm noise as so. And it will also give a prompt on the screen to let you know what has gone wrong. In this prompt, it will ask you or encourage you to troubleshoot the issue. Common issues could be with high flow, and that could be because there is a leakage of air from the interface or the circuit, and we would advise that you check your circuit for leaks and you check that your interface is correctly fitted. I would encourage that if your NIV system were to make an alarm, that you act on it immediately and try to troubleshoot it as best possible. If you have any concerns or you're unable to troubleshoot the alarm, then I would advise you to consult with your local respiratory specialist. Next, we're going to apply the interface to our patients so they can receive their non-invasive ventilation. We're going to use the approach of mask on, then ventilator on. For removal of the mask, it will then be ventilator off and then mask off. We feel that this is the easiest way to apply the interface to your patient. The interfaces come in 3 sizes commonly: small, medium and large. And it's very important that you pick the appropriate size for your patient, not only for patient comfort, but to make sure that the mask forms a tight-fitting seal so the patient can receive their therapy as best possible. Within most of the interfaces that you'll be dealing with, you will see sizing charts. I'm using a sizing chart here from Fisher & Paykel Healthcare. The sizing chart helps you to identify the appropriate size for your patient. How you're looking to measure is you're looking to measure from the nasal bridge just to the chin, or just the cleft of the chin, or the space between the lower lip and the chin. As you apply your sizing chart as so, as I say, you're looking to see the interface to be here at the chin to the bridge of the nose. As you can clearly see, Anne-Marie would fit the small size of mask. If it was medium, her nasal bridge would be here, and large would be here. We've selected the small size interface for Anne-Marie. The first thing I will do is I will release the buckle here on the side of the mask. Next, I will take the headgear and I will move it to the side. I will have explained to Anne-Marie the purpose in using this therapy, and I will give her reassurance and coaching as necessary in how she can try to synchronise and work with the ventilator to achieve the optimal therapeutic response. In application of the mask, I will first apply the lower section of the mask and roll it onto Anne-Marie's face, as demonstrated now. At this point, if the patient can hold the mask in place, or another member of staff can help you. Next, I will apply the headgear. And as you can see, the headgear has got a strap at the top called the halo strap, designed to sit over the top of the head to give support. You're going to have 2 support straps here at the top of the head, and you're going to have straps here designed to sit below the ears. What I will do first is I will connect the buckle. Next, what I will do is I will look to adjust the straps to help to keep the interface secure and in place. I will start by adjusting the top straps, and I would like to do them both simultaneously. Are you doing okay, Anne-Marie? Mm-hmm. You can see that they are Velcro straps. Ask your patient and reassure them that it's not too tight or uncomfortable, and adjust as so. Next, I will do the same process on the lower straps. At this point, coach and reassure your patient that it will feel tight. When we talk about tightness of a mask, we don't want it to be too tight to cause pressure damage or cause discomfort to your patient. As your patient releases the mask, they should feel the mask spring back slightly from the face. How's that, Anne-Marie? At this point, it can be good to do something we call the toggle test. Take the elbow of the mask and just give it a little bit of a toggle to see that it's in place and that it's secure. It's at this point we're ready to switch on and start the therapy. It's important to educate your patient and staff looking after patients in non-invasive ventilation about the safe removal of the mask. Where possible, you want to educate the patient themselves to self-remove the mask in the case of an emergency. And the most commonest emergency that we think about or consider is if the patient was going to vomit, because it will increase their risk of aspiration wearing a tight-fitting mask. We would encourage our patients to try to locate the buckle located on the side of the mask, to push the button in to release the mask like so. We also reassure the patient that there are Velcro straps, and if they were unable to remove the mask without healthcare staff present, that they can try to locate the Velcro and remove the mask themselves. In removal of the mask, as I say, we've employed the strategy that you would switch the ventilator off at this point, and then you would remove the mask as so. It is important at this point to recommence the patient back onto whatever oxygen therapy, should they have been on oxygen therapy before they started the non-invasive ventilator, whether that be nasal cannula or an oxygen mask. Major complications in the use of non-invasive ventilation are relatively rare, but minor complications are common, and we've given a list of the common complications you may see. Mask leak is a common complication, but it must be resolved quickly, because if it is not resolved, then the patient is not receiving their ventilation therapy. This can involve refitting of the mask. So sometimes with the mask, it can become displaced. And to troubleshoot that, you just may need to undo the buckle and refit the mask to see if that helps to correct the seal from the mask leak. Sometimes you need to resize the mask. Perhaps you've used the wrong size mask and you're not getting an effective seal. Or perhaps you need to remask, and that means considering a different or an alternative interface, such as a total face mask or a different style full face mask. We would ask that you discuss with your local respiratory specialist should you be having mask issues or problems. Pressure ulceration is a common problem, particularly if it happens on the bony part of the nasal bridge. And that can really impact on the patient's ability to comfortably tolerate non-invasive ventilation. You can consider different type of dressings. A common dressing we use is a hydrocolloid dressing that protects the nasal bridge, but again, you may need to consider a different style of mask that does not sit onto the nasal bridge. Again, liaise with your local respiratory specialist. It is very common that patients experience aerophagia when they're receiving positive pressure, and that's where they get abdominal distension because they're swallowing the inspired positive pressure. So what you may need to do is you may need to look to see if your patient is adequately synchronizing with the ventilator. Perhaps the positive pressure on inspiration is too high. Sputum retention can be a particular issue, particularly with patients with underlying conditions such as bronchiectasis. We would encourage the active involvement of physiotherapy, and you can consider other techniques such as humidification. For patients that you are managed with suspected or confirmed COVID-19, the use of humidification through the NIV systems is currently not recommended. Remember, patient comfort and adherence to the non-invasive ventilator are key in determining their outcome. We would encourage that you consider that you have got the appropriate interface and that it is well fitting. We would encourage that you frequently review the NIV circuit, making sure it's the correct setup, paying particular attention to what we have said about the different setup with patients with suspected or confirmed COVID-19. Observe your patient for a therapeutic response. Look to see that you're achieving the targets of therapy. You're looking to see that the patient's respiratory symptoms are improving appropriately with the use of the non-invasive ventilation. And of course, observe for the patient's tolerability. Make sure that they are comfortable and that they are tolerant in using the machine to achieve a therapeutic benefit. In summary, the management of respiratory failure is a multidisciplinary patient-centered approach. Non-invasive ventilation should only be commenced after appropriate clinical assessment, examination of the patient, and a formal and realistic plan is established. And included within this is the escalation plan should the patient fail on this therapy. Thank you for listening.